So Dr. Slovin, are there differences among these agents in how they work, and what are the long-term sort of cardiovascular risk profile with these agents?
A great question, Dr. Gupta. So if we were just to take a look here, we are modulating androgens, and that's really where we have the problems. We do know that when we give a GnRH agonist, that there is a disconnect between the brain and the gonads. And in doing so, that feedback that we always talk about, the feedback loop of having the testosterone get the signal from the hypothalamus is completely obliterated. And during that time period where the gonads just don't know quite what to do and they don't get the signal from the brain, what ultimately happens is that there is that surge. And what you can see here with an agonist is that the testosterone goes up well before it goes down. And if you happen to have the misfortune of having a very large prostate or widespread metastatic disease, that sudden flare in testosterone could cause urinary obstruction, for example, or can cause pain. The difference is, however, if you use an antagonist, as you can see on the left, is that you have an immediate decline in serum testosterone such that you do not have that flare, ergo you don't have those side effects that can be seen, and it actually can drop the serum testosterone usually within a good 24 to 48 hours, whereas the agonist, as you see in red, may take as long as 14 to 21 days and is predicated by the use of a bicalutamide or another anti-androgen that will block the androgen receptors and prevent the flare. So we think of giving hormonal therapies as something very lightweight, but remember, you are inducing physiologic changes in the body that really can be long-term, and particularly the longer they're on treatment, the worse it actually becomes. Now, we are not only discussing changes physiologically, but we're also seeing changes in the immune system. And while there have never really been prospective trials that will look at changes in the immune system, I've actually taken this quote from an article that was looking at hypogonadotrophin deficient or hypogonadism in men, and it was actually found that you do need testosterone for a variety of different things. And they found actually that when you have no testosterone, you actually have an enhancement of cellular and humoral immunity. Now, they looked at this in preclinical, but there was a correlation suggesting that somehow testosterone does play a role in the immune system. What about the increasing risk that I've alluded to? Well, if you can see here, we're looking at the incident risk of cardiovascular disease, myocardial infarction, sudden cardiac death, stroke, and in patients who have had no androgen deprivation therapy, and unfortunately I don't have the numbers on it, but I can tell you that if you look at those patients who had a treatment with a GnRH agonist or orchiectomy, you can see that the risks are high. The problem with many of these studies, however informative, is that they have been observational. This is a large study of close to 40,000 patients, and you can see about 40% of these patients received some form of androgen deprivation therapy, many of whom had these LHRH agonists. Very few were treated with orchiectomy, some of them had anti-androgen, but the point is there was data to support our concerns about the role of cardiovascular disease. There was a move by the FDA as well as European agencies to put a black box warning, which ultimately happened, for the use of androgen deprivation therapy, in particular GnRH agonists. And this came as a result of a review of several studies that were very tantalizing in their recommendations that perhaps the risk of cardiovascular events was much higher in patients who underwent androgen deprivation therapy. If one were to go back and sort of look in the retrospectoscope of the data, these were all based, again, on retrospective studies, nothing that was randomized, and everybody came to the conclusion that there was definitely an enhanced risk of cardiovascular disease, but at the end of the day, no recommendations were made into how we can bring in a cardiologist or somebody who's a primary care specialist or somebody to really manage what do we do about it. And if you read the fine print, they actually say We're not sure what kind of recommendations. We recognize that this is something that's ongoing, but we just don't know what to do about it. And we're not so sure that one needs to go through a lipid profile or any other workup before we do anything. And we're not quite sure, maybe we should wait a year before we really assess anything with cardiovascular.